Hello, everyone. This is Dr. Mickey recording a lecture on Chapter 42, which is the drugs for bowel disorders and other GI conditions. So, first slide is learning objectives or outcomes from this lecture, and then this slides provide like the brief illustration or brief description of the small intestines or the responsibility of the small intestine and the large intestines, and in which that the large intestine are responsible for reabsorption of water and the excretion of the fecal matter, which is the bowel movement, or like the stool. The two main conditions we're going to review or go over in this chapter, which is includes the constipation and diarrhea, the difference between them, treatment for each disorder. So the first one is the constipation, which is defined as an infrequent passage of a dry, hard stool. So it is about the frequency of having a bowel movement and the consistency of the bowel movement. So it's an infrequent passage as well as the consistency, which is the hard, dry stool. The etiology, what could be like, the reasons and causes of this condition. Constipation can be caused by the lack of exercise, the insufficient dietary fiber, the diminished fluid intake, slow motility of waste material through the large intestine, which pertains to the slow movement or peristalsis. There are certain medications, food, diseases that are associated with constipation. An example of the medication would be like the calcium channel blockers, CBC drugs. The actions of the laxative and the cathartics, that the bulk-forming agents, stool softeners or surfactants, the saline or osmotic laxative, they add more bulk or water to the colon content and make it less dry and hard, and which will facilitate the passage of less hard stool, which which will aid and assist in the more liquefying, like making the hard stool more liquefied and less hard. The stimulants also and herbal agents, stimulants, they will stimulate the like herbs, some sort of herbs that also will stimulate peristalsis. The mineral oil as well also is another product that mineral oil will lubricate the fecal mass. So medications that to treat the constipation pertains to a group of meds called laxatives, and we have a quite good number of these products. One of them is the bulk forming laxative like psyllium, and we have in this kind of included in this slide the expected mechanism of action and the therapeutic uses for each type of these drugs and medications. Another drug, which is docosahexaene sodium, which is a surfactant laxative. Bisacodyl or senna, they are stimulant laxative. The magnesium hydroxide lactulose, they are osmotic laxative. So for each type of these laxatives or these group of laxatives, an example of each group, we have the expected mechanism of action and the specific uses for each type. So if we take, like, for example, the psyllium, which is a bulk forming laxative. So it's a bulk forming laxative which will soften the fecal mass and increases the bulk, make it more bulky, which will make more, which increase the sensation or um, the it's kind of like which is identical to the action of dietary fiber, makes exact same function as if we are eating a high fiber diet. We will pretty much prescribe it or recommend it for temporary treatment of constipation, to decrease diarrhea in clients who have diverticulosis and irritable bowel syndrome. Also, it will control stool for clients who have ileostomy or colostomy. Doxycycline, which is a surfactant laxative, and which that will lower the surface tension of the stool to allow more penetration of the water, and that will soften the stool so it would can pass easily through the GI tract. That's an example of the uses or the recommendations that the doxycycline or Colis is recommended for treatment of major or many different types of constipation. It's kind of like constipation related like conditions, most related to the GI tract, and in which that it will soften the fecal matter or the fecal impaction. And you can go on, to review the rest of the mechanism of actions for the rest of the medications, such as bisacodyl or senna or magnesium hydroxide or lactulose. So the psyllium or metamucil, which is brand name for psyllium, again, it's an herbal agent. It's a bulk type laxative. The psyllium comes in a 7 gram of a packet, like a powder, will be mixed in liquid form, juice or water, right? Type of preferred liquid form. So it comes in like 7 grams packets of psyllium powder form, and causes more reduction. In addition to being laxative, also it has an additional outcome or positive outcome, which is a reduction, small tiny fraction of reduction of blood cholesterol level can be lowered with psyllium metamucil. And because of this effect, the psyllium may be used as part of a regimen to reduce the risk of coronary artery disease, CAD. The adverse effects, the psyllium is a safe laxative that is rarely produce any adverse effects. It causes less cramping than the other stimulant type of laxative, and it results in a more natural bowel movement. It's a safe drug, less side effects, more effective, and the outcome or the positive outcome of this, that it's in addition to that, it lowers the cholesterol level slightly, but also it's a stimulant, a type of laxative that will lead to a more natural bowel movement. It takes with, or if we will recommend that, we take it with the um, a good amount of or volume of fluid. So it should be taken with a good at least 6 or 8 ounces of water or juice, or because if taken with insufficient water, then the psyllium may result in the esophageal um, problems like obstruction. So esophageal obstruction may result from taking the psyllium with a small or insufficient amount of water. So it should always be taken with a good amount of water or juice. So the contraindications, it should not be administered to patients with undiagnosed abdominal pain, or with patients with intestinal obstruction, or patients with fecal impaction. So we have to treat the underlying cause, if that is the abdominal pain or intestinal obstruction or fecal impaction should be treated, that underlying cause, before going, further to treat the manifestation, which is the constipation. So the interactions, it may decrease the absorption and effects of some medications, certain medications like Coumadin, warfarin, sodium, digoxin, nitrofurantoin, antibiotic for UTI, um, uh, TCAs, tricyclic antidepressants, carbamazepine, which is Tigritol, anti-epileptic, anti-seizure drug, and the salicylates like the aspirin. Psyllium lab tests may reduce the serum glucose levels in patients with diabetes type 2. So psyllium, again, should be mixed with uh, at least 8 ounces of water. You can add fruit juice, we said, milk, or administer immediately. So it should be administered immediately and after being mixed with water, juice, or milk. And we recommend, in addition to mixing the Metamucil with any type of preferred liquid, and take and administer immediately, and also follow each dose with an additional 8 ounces of liquid, and preferably would be water. So we observe also the older adults closely for possible aspiration. Now the complications, GI irritation. So the client indication is to not crush or chew the tablets, if that were like laxative tablets, laxatives, not to crush or chew them, for to prevent this GI irritation. Rectal burning sensation leading to proctitis. So the client education is not to do not use Bisacadiol suppositories on a regular basis, should not be used on a regular basis, the Bisacadiol suppositories. Toxic magnesium levels. The laxatives with magnesium salt, like magnesium hydroxide, can lead to the accumulation of toxic levels of magnesium. So another nursing action would be for clients experiencing impaired kidney function, like patients with chronic kidney disease, patients with end-stage renal disease. Read labels carefully and avoid laxatives that contain magnesium, because they have a renal failure and the kidneys will not be able to excrete magnesium, and they may end up with magnesium toxicity. Sodium absorption and fluid retention. The laxatives with sodium, like salt, like phosphate, they will place the client at a risk for sodium absorption and fluid retention. So what's the nursing action would be recommended for this, to prevent this condition, is to monitor the patient for fluid retention. So we still would give it, but we have to be careful, cautious about this by monitoring the patient's fluid retention, signs of fluid retention. Dehydration. Osmotic diuretics can cause dehydration. And an example of this osmotic diuretics would be medications such as the magnesium hydroxide lactulose. Lactulose, that's an osmotic diuretic agent. So we have to monitor the patient for intake and output, monitor and assist patient for manifestations of dehydration, and the client education include that recommend to increase water intake at least 8 to 10 ounces of water per daily, And obstruction, another complication. It's the bulk. So the bulk forming agents can cause obstruction of the esophagus or intestines. Now, the nursing actions should include that we will administer the medication with a full glass of water or juice and avoid use if client has narrowing of the intestinal lumen. So if patient has been diagnosed with any condition like strictures or intestinal narrowing narrowing of the intestinal lumen, then that is contraindicated because that's going to result in obstruction. Then next, or the other condition here after constipation is the opposite, which is diarrhea. So it's another complication. So the laxatives are contraindicated in patients who have fecal impaction, as we said. Um, Prior to talk about diarrhea, just to complete one more sentence or one more concept about the constipation pertains to the contraindications and precautions. The laxatives are contraindicated in patients with fecal impaction, bowel obstruction, and acute surgical abdomen to prevent the perforation. They are also contraindicated in patients or clients who have nausea, cramping, or abdominal pain, as we mentioned earlier. The laxatives also, they may interact with milk and antacids and destroy the enteric coating of the bisacodyl. So bisacodyl laxative, it's enteric coated medication, so the enteric coating of this bisacodyl can be destroyed by the milk or and the antacids. So that's an recommended client education to educate patients to take bisacodyl at least 1 hour apart from the taking or ingesting these substances, milk or antacids. Okay, so diarrhea, as we said, it's the opposite to the previous condition, which is constipation, which that there is an increase in frequency and consistency, which is the fluidity of the bowel movement, more watery, fluidy, and bowel movement in addition to the consistency, or I'm sorry, the frequency, increased frequency. So it's a type of body defense. In other words, that it eliminates the toxins and pathogens in a way that it will be like the part of the body defense mechanism. It also eliminates certain medications and infections, kind of excretes all of these unwanted or poisonous stuff from the body. So if prolonged, can lead to fluid, electrolyte, and acid-base imbalance. So that's why we have to monitor the patient frequently because that may be related to the C. diff. So the pharmacology for diarrhea, the medications, the opioids for severe diarrhea, they're most effective because they're going to slow peristalsis. So the treatment depends on the severity and the etiology of the problem or the condition. Again, the opioids for severe diarrhea, they are very effective or most effective, and in which they will slow the peristalsis. Medications for mild diarrhea, the loperamide, Imodium, Pismo, subsalicylate, which is piptopismol, and the probiotic supplement, which is the lactobacillus. So It's recommended not to use it if constipation, so do not use if constipation should be avoided. And you assess the patient's ability to get out of bed safely. The antidiarrheal contraindicated in some patients, like patients, those with severe dehydration, electrolyte imbalance, patients with liver and renal disorders, patients with glaucoma. So the prototype drug is a diphenoxylate with atropine, which is Lomotil. So like other opioids, diphenoxylate slows peristalsis, allowing time for additional water reabsorption from the colon and more solid stools. So within like 40 to 50 minutes, it acts within this time frame, 45 to 50 to 60, sorry, 55 to 60 minutes. It acts within this time frame. It's effective for moderate to severe diarrhea, but is not recommended for infants. The atropine is added to Lomotil, or in Lomotil, we have atropine as one of the products in Lomotil is atropine. So the atropine in Lomotil is added not for any therapeutic effect, but to discourage patients from taking too much of the drug. So again, the atropine is added to this Lomotil, not for any therapeutic effect, but to discourage patients from taking too much of the drug. And at high doses, remember that atropine is anticholinergic drug. So the anticholinergic drug or anticholinergic effects of atropine, such as drowsiness, dry mouth, tachycardia, will be experienced. So patients will exhibit symptoms of anticholinergic effects from thinking if they take too much of the drug. So that's why the atropine is added to discourage patients from taking too much of the drug. So the diphenoxylate is discontinued as soon as the diarrhea symptoms resolve. Adverse effects. So unlike most opioids, diphenoxylate has no analgesic properties and has a very low potential for abuse. Now, the drug is well tolerated at normal doses or average doses. Some patients experience dizziness or drowsiness, and they should not drive or operate machinery until the effects of the drug are known. The contraindications include hypersensitivity to the drug, obstructive jaundice, diarrhea associated with certain other conditions, such as the PMC, which is pseudomembranous colitis, like C. diff. Now, if severe dehydration or electrolyte imbalance is present, it should be corrected before administering the drug, before administering Lomotil. So we should be taking care of the underlying problem like electrolyte imbalance or dehydration should be treated and corrected and resolved before taking or administering the Lomotil. Now, diphenoxylate, it interacts with other CNS depressants like alcohol. So when taken with, for example, with MAO inhibitors, the monoamine oxidase inhibitors, the diphenoxylate may cause hypertensive crises. So one more time, when the Lomotil is taken with MAO inhibitors, the phenoxylate may cause hypertensive crises. mean, in terms of lab, because of these two components, the phenoxylate and atropine, they may increase the serum amylase. Now, treatment of overdose, the overdose of the model may be serious, so the narcotic antagonist, such as naloxone, Narcan, may be administered parenterally to reverse the respiratory depression within minutes. Next condition, which is the IBS, irritable bowel syndrome. Irritable bowel syndrome, also known as the spastic colon or mucus colitis. The symptoms may include abdominal pain, cramping, bloating, gas, the constipation alternate with diarrhea, mucus and stool. That would be more prominent in patients with, for example, the ulcerative colitis or Crohn's disease, and we'll get to the differentiate in the upcoming slides the difference between ulcerative colitis and Crohn's disease. Functional bowel disorder, in which there is an impaired function with no detectable disease. So stress and dietary factors may precipitate the symptoms. IBS, the treatment, we have to be cognizant and aware of or able to identify the triggering factors and try to avoid them. So we can reduce the frequency and the exacerbation of the disease process. And so the supportive symptomatic treatment, depending on whether the constipation or diarrhea is major presenting symptom. So the patient during the disease process, sometimes they do develop like alternate between constipation versus diarrhea, and so we're going to treat each condition separate. It depends on the severity of the problem, and the medications for the IBS will include the anticholinergic medications, and which that these meds will lower the bowel spasms, like the um, um, dicyclomine, bentyl, uh, allosterone, which is Lutronics, and the eloxadoline, which is Viberzi, and the rifaximin, which is Xivaxan. The most commonly and widely used from this list is the bentyl and the Xivaxan. Bentyl and Xivaxan. Um, so the IBD, inflammatory bowel disease, which includes ulcerative colitis and Crohn's disease, in which the irritable bowel disease refers to the disorders of GI tract with no known etiology, either it's ulcerative colitis or Crohn's disease. Now, the IBD, which includes both conditions, UC and CD, it's more prevalent among white and in industrialized regions of the world, and it's characterized by chronic recurrent inflammation of the intestinal tract. Now, the manifestations or clinical manifestations, they are varied. We can differentiate between, even though there's a lot of similarities between ulcerative colitis and Crohn's disease, we will be able to differentiate between these two conditions to some extent. There are some different, we can differentiate. So, but there are a lot of similarities between these conditions. So, long periods of remission intercepted with episodes of acute inflammation. So patient during this disease process will have a periods of remission and very um, uh, low manifestations and symptoms and symptomatology barely experienced compared to periods when the patient is having the exacerbation in which there is an extremely high and acute heightened symptoms and acute manifestations of inflammation. So both ulcerative colitis and Crohn's disease are diseases that can be debilitating and causing like general weakness and other complications, and we're going to cover some of these complications. So from this slide, you can at least just identify some of the differences between Crohn's disease and ulcerative colitis. If you look at the ulcerative colitis here, you'll find that the inflammation of the bowel is continuous from the transverse, descending, and colon. Colon and the rectum. So transverse colon, descending colon, and rectum. So all of this continuous inflammation in this area is consistent with the ulcerative colitis. Now, however, with the Crohn's disease is interrupted areas in which there is like skip lesions, and in which there is the interrupted inflammatory process or inflammation of interrupted sections or segments of the bowel, in which you will find that this is healthy. This section or segment of the colon is healthy. This is called skip lesion. Skip lesions. The lesion that is skipped the ulceration or skip the inflammation or the inflammatory process. So the lesions or the sections or segments that in which that you skip the inflammation is called skip lesions. So again, it's more frequently to be present in the terminal ileum, ileocecal valve, ascending, and all other, the rest of the colon, ascending, transverse and the descending colon, and in which that, it's kind of, encompass all different aspects of or segments of the colon, but it's interrupted and it's not continuous like the ulcerative colitis. Another difference between ulcerative colitis and Crohn's disease is that a Crohn's disease, given the disease process that it affects or involves the small intestine, then there is a problem with the absorption of nutrients. So patients will be having more severe nutritional malnutrition. Patient will have a loss of weight significantly, compared to severe compared to the ulcerative colitis. So more because of the intramural affects all the layers of the small intestine and large intestine. So it's can be, patients may develop a. We'll talk about the complications later on, but here is more a wasting, weight loss and nutritional deficiencies, in which is or malnutrition will be present and evident in patients with Crohn's disease compared to the ulcerative colitis because of this fact or this disease process. So the ulcerative colitis is, again, the cause is unknown, but there is genetic and environmental factors that may play a role in the development of this disease. The antigen initiates the inflammation, in which the actual damage is due to the overactive, inappropriate, and sustained inflammatory process or response. So the inflammation, it is overreactive, it's inappropriate, and it's sustained. So it's going to result in all these symptoms we're going to cover in the upcoming few slides. So possible causes, etiologies, we can include infectious agents like bacterial organisms, autoimmune reaction following following support of the autoimmune theory, because when we will find that some of the complications that are out of the GI tract, like the swelling of the lower extremities, for example, and other conditions out of the GI tract, supports the autoimmune reaction or autoimmune disease. So the following support this autoimmune theory, such as there will be extra-intestinal manifestations of the disease process, which would support this theory. It's an autoimmune reaction. There is the presence of the epithelial antibodies like IgG, immunoglobulin type G, in the blood in some patients with ulcerative colitis. It supports this theory that it's an autoimmune disease or reaction. Food allergies and the genetic predisposition. Some studies of twins and family members provide support of this genetic influence. The incidence, 2+ million cases in the US. The patients or the disease characterized by inflammation and ulceration of the colon and rectum, affects all age groups equally, also affect both genders. So women are more affected than men at a younger age. Men have the disease more often as middle-aged or older adults. What they found, astonishing kind of result, and it's kind of unusual. They found that people who do not smoke or who quit smoking are at higher risk for having ulcerative colitis than those who smoke. So that's one of the results of some of the research studies. Now, the pathophysiology of ulcerative colitis is diffuse inflammation, in which that it's continuous, as you have seen in that slide or that figure. It's continuous, diffuse inflammation, and it's continuous. So it's widespread inflammation. Involves mucosa and submucosa, and it alternates periods of exacerbation, it's like flare-ups, with remission states. So patients may, have the exacerbation periods of heightened manifestations in which that there's an acute inflammation. Patient will be required, like we anticipate or require that we have to take care of the patient at the acute care setting, in which that when that subsides, patient is stabilized, and patient is back to the remission state. Patient will live a fairly normal life with very minimal symptoms, tolerated very well, and that's a remission state. So exacerbation versus remission state. The ulcerative colitis is, again, it's confined to the large bowel, although as we said, it's the continuous. And the X-ray, it will show as what is called the backwash ileitis. That will be evident in the terminal ileum when the disease is extensive, and that's very prominent. Will be in the barium enema and the X-ray or the barium enema studies. The mucosa is hyperemic. There's an increased blood flow, and there's going to be reflected on the diagnostic studies like endoscopy as edematous, swollen, hyperemic areas. Severe inflammation by ulcerative colitis, according to the Iggy textbook, the lining bleeds, so there's a bleeding that will lead to the mucosa. There's a bleeding, mucosal bleeding, that will lead to the ulceration. So bleeding and then ulceration, and then the ulceration becomes like an abscess from this ulcerative areas ulceration, and the abscess will lead to necrosis. So this is kind of like sequence, and the ulcerative colitis, the inflammation, the bleeding, ulceration become abscess, the abscess becomes necrotic tissue, and then there'll be a thickening of the bowel that may lead to a partial bowel obstruction, which is the expected complication from ulcerative colitis. And the stool contains blood and mucus. This is another difference between Crohn's disease and ulcerative colitis. In ulcerative colitis, you would expect that there is a more frequency of watery um, um, diarrheal kind of stool that is mixed with blood and mucus, more seen in patients with Crohn's disease. The backwash colitis, as being seen in the barium enema or studies, hyperemia and hyperemic edematous, reddened, and ulcerations and an abscess. Things are called like pseudopolyps, seen in patients with ulcerative colitis. These are like severe ulcerative colitis, extensive pseudopolyps, polyps filled with blood and ulcerations and edematous ulcerations, and then becomes like scar tissue. And so that's extensive pseudopolyps. So in ulcerative colitis, there's a multiple abscess that would develop in the intestinal glands. The abscess will break through into the submucosa. They will leave and cause ulcerations, and that will, result in fluid electrolyte imbalance or loss, protein loss, pseudopolyps. Um, so in terms of clinical manifestations, response to all of these pathophysiological changes and the pathophysiology of the disease process of ulcerative colitis, most commonly present as a chronic disorders. It's chronic disease. Now, the classification in which we said there's, acute exacerbation and remission, right? So there's the remission versus exacerbation phase. And we explained that, the difference between exacerbation and remission earlier. Now, the classification of the ulcerative colitis, in the book, there is like a table explaining the difference between or the criteria for the classification of ulcerative colitis in terms of mild, moderate, severe, fulminant. So, for example, like mild, when there is a less than 4 bowel movements a day with or without blood, patient is asymptomatic and patient fairly have a normal lab values. Moderate, when there is more than 4 bowel movements daily, with or without blood, with minimal manifestations like abdominal pain, intermittent nausea, elevated CRP, or elevated ESR. Severe, when there is patient has experienced more than 6 bloody bowel movements in a day, and patient had experience also with fever, tachycardia, anemia, abdominal pain, elevated CRP, and or elevated ESR. Now with fulminant, and that's the heightened or the highest level of the disease process, in which the patient will have more than 10 bloody bowel movements in a day, increasing symptoms, become more anemic, and in which the patient may require the blood transfusion, and patient probably also would have a colon distension on the X-ray. Like X-ray shows that there is a bowel or colon distension. Now, the major symptoms, bloody diarrhea, abdominal pain, and the abdominal pain, it's specifically is going to be reflected, indicated in the or experienced in the lower abdomen. So it's kind of lower abdominal colicky pain, very severe pain. So colicky severe pain, relieved with, so patient will have this lower abdominal colicky pain, which will be relieved with defecation. When patient have a bowel movement, all of this pain is going to be resolved to a large extent. tenesmus, which is the unpleasant and urge sensation to defecate or to have bowel movement. Patient also will experience the malaise, general weakness, anorexia, weight loss, anemia. But again, remember that the weight loss would be and the malnutrition would be more prominent or, evident in patients with a Crohn's disease than ulcerative colitis. And also patient may have anemia and a low grade fever. Now the complications, hemorrhage, strictures, perforation with peritonitis, toxic megacolon, and colon dilatation. Now the extraintestinal manifestations. The extraintestinal manifestations, like for example, I'm going to focus on the toxic megacolon. Toxic megacolon. Now, the complications like toxic megacolon, not the extraintestinal manifestations includes the conditions outside the GI tract, extraintestinal, or outside the intestines. So they are, or maybe non-specific complications medicated or initiated or mediated by a disturbance in the immune system. So, that the extraintestinal, again, these are conditions. The presence of these extraintestinal conditions or complications, they support the theory which explains or try to explain the disease, the pathophysiology of the ulcer of the IB or of the IBD or the ulcerative colitis as an autoimmune disease, because we are seeing these type of extraintestinal complications. An example of that would be the edema of the lower extremities. There are some skin lesions, for example, eye inflammation, thromboembolism, gallstones, like stones in the gallbladder, kidney stones, and other conditions that would support the autoimmune disease theory. So again, the extraintestinal complications, they support the autoimmune theory that this disease is caused by the autoimmune as an autoimmune disease or autoimmune response. So back to the toxic megacolon, as there's a lot of discussion of, or content over the toxic megacolon, in which that it's a dilatation and paralysis of the colon. So there is a dilatation and paralysis of the colon. And about 5% of patients may develop this toxic megacolon. Now, the problem with the toxic megacolon, it may lead to perforations, always associated with intestinal perforation. So what is megacolon, or the toxic megacolon? It's a severe episode of colitis with segmental or total dilatation of the colon. It may affect small part, or the entire colon. So it's a severe colitis with dilatation of the colon. So it's typically a complication of ulcerative colitis, but may also result, or maybe a complication of Crohn's disease as well. But you will see it more frequent in patients with ulcerative colitis. It is a potentially lethal complication of inflammatory bowel disease that is characterized by non-obstructive colon dilatation plus systemic toxicity. So this widespread inflammation accounts for this toxicity, which is megacolon systemic toxicity, which includes fever, tachycardia, localized abdominal pain, and leukocytosis, which is elevated white blood cells. And we'll talk more about the toxic megacolon in mid-surge or adult health courses and the treatment of patients with toxic megacolon. The diagnostic or studies or blood studies like CBC, elevated white blood cells, leukocytosis, platelet, CRP, C-reactive protein, ESR, erythrocyte sedimentation rate elevated as well. Electrolytes also, we find some electrolyte imbalances from the malabsorption of these nutrients and vitamins. There is also the hypoproteinemia, like low albumin, and low protein levels. So sigmoidoscope and colonoscope examinations. The colonoscopy is the most definitive test for diagnosing ulcerative colitis because the ulcerative colitis begins in the rectum, then the biopsy may be adequate for diagnosis. So when we do colonoscopy, we can take also biopsy. So that's colonoscopy is the most definitive test for diagnosing patients with ulcerative colitis, in which that we can also take a biopsy and for pathology. So the colonoscopy determines the extent of the inflammation, will determine the extent of the presence of the pseudopolyps, and if there is any strictures. And in addition to that, we can take a biopsy as well. So the treatment for patients with ulcerative colitis, I mean, the goal of the treatment is to rest the bowel and to control the inflammation, to correct the malnutrition, to alleviate the stress, to treat the infection if present, and to provide some symptomatology or symptomatic relief. So for diarrhea, we will treat for the diarrhea. We will record the color, volume, frequency, and consistency of stools. We will identify the factors, if that's the medications, bacteria, tube feeding, what kind of factors. So identify the factors that cause or contribute to diarrhea. Eliminate the gas producing and spicy foods. Eliminate any trial food containing lactose. Eat to educate patients to eat a low fiber, high protein, high calorie diet, and that's again to treat diarrheal episodes. To use anti-diarrheal medications. So medications will include the aminosalicylate compounds, steroids, immunosuppressive drugs, antidiarrheal medications like Imodal, Imodium. So the most effective drug for ulcerative colitis and Crohn's disease is the sulfasalazine or zolpidem, which is the same family as the sulfonamide antibiotics. So patients who are allergic to or sensitive to the sulfa should be contraindicated to take any um, uh, should not take this drug. So the drug is used and very effective. In 2 to 4 weeks, will show effectiveness. And it's very effective in mild to moderately severe attacks. However, the side effects of the aminosalicylate 5-ESA side effects include the nausea, vomiting, anorexia, so GI disturbances, headache, folic acid malabsorption. The higher doses of this drug may lead to rash, hemolytic anemia, hepatitis, male infertility, and agranuloses or agranulocytoses. Now, there are three main types or subforms of the mesalamine, which is acetol, pentasa, or wanza. So the acetol, which is better tolerated than sulfasalazine with side effects of headache and GI upset. It's an enteric-coated drug released in the terminal ileum and the right side of the colon. The pentasa, which is a delayed release drug, released throughout the small bowel and colon to the rectum. There are ones which is suppository or enema used during the nighttime to treat left side disease. So don't understand, it's really difficult to differentiate between the three types, but all what you need to know is that, all the three medications are effective for the ulcerative colitis. There are some differences in terms of that, the PO or suppository formula. Steroids, corticosteroids, they're prescribed during the exacerbation of that disease. So during the heightened manifestation of the disease process, we prescribe or recommend corticosteroids like prednisolone or prednisone 40 to 60 up to 65 milligrams, 40 up to 65 milligrams daily. Then we will taper off the medication later on, and then discontinue the drug. Steroid. There's also some enemas like steroid small retention enemas may be prescribed. The enema, which is like hydrocortisone enema, for prescribed for like 21 days and then tapered off and then deseed. The immunosuppressive drugs like azathioprine, cyclosporin, methotrexate, drugs which will alter the immune response, change the immune response, make it less heightened and may have also synergistic effect with the steroids. These slides provide more information about the medications and the side effects from the ATI. So before we get to we start going over the Crohn's disease, the last thing about the nutrition or dietary recommendations for patients with ulcerative colitis is that during the acute phase, patient will be on PO, on liquid diet. Patient might be also on a TPN for severe cases or malnourished cases. TPN. The and to teach patient to limit or omit foods that cause discomfort or diarrhea, like lactose-containing foods, caffeinated beverages, alcohol, pepper, small, the tobacco or like smoking. All of these are common GI stimulants to the GI tract. Smoking, peppers, alcohol, caffeinated beverages, lactose-containing food. All of these are stimulants to the GI tract, should be avoided. Some of the complementary and CAM therapy, things like flaxseed, selenium, vitamin C, all of these are good for patients with ulcerative colitis. Surgical interventions, the surgical interventions and the other modalities will be covered in adult health courses. Now, Crohn's disease, which is chronic, non-specific inflammatory bowel disease or disorder of unknown origin that can affect any part of the GI tract from the mouth to the anus. There is they kind of mapped the genes and they identified some specific genes associated with the Crohn's disease. This is more confirmed genetic disease than ulcerative colitis. Given that for Crohn's disease we have identified 2 genes on chromosome 16 for Crohn's disease. So pathophysiology, characterized by inflammation of segments of the GI tract. Remember that Crohn's disease, it's interrupted segments of the GI tract. There are skip lesions, areas that are not affected by the disease process. So it can affect any part of the GI tract, but is most often seen in the terminal ileum, jejunum, colon, which is ascending, transverse, and descending colon, and in addition to the rectum and anus. So the inflammation involves all layers of the bowel wall. So it's a transmural inflammation causing thickened bowel wall. In other words, that given that it's transmural, so it will and affects the small intestine, so it's merely to severe malnutrition and weight loss compared to the ulcerative colitis. Again, there is skipped lesions. And these skipped lesions, these are the segments of the normal bowel occurring between diseased portions, which is going to look like a cobblestone appearance, ulcerations and strictures. So the prominent, you can call it manifestation or complication here, is that patients would be predisposed to develop a complication of fistulas. And we have 2 different types of fistulas. One of them is the external intracutaneous, which is the fistula, little tiny pathway or canal or passage between the skin and the intestine, and the enteroenteric one, which is between the intestine and the intestine. And that's how the cobblestone appearance look on the slide as a complication or manifestations of or changes, actual changes in the bowel consistent with the Crohn's disease. And these are the 2 different types of fistulas. One of them is the here is the external intercutaneous between the skin opening between the skin and the intestine, and this is enteric between intestine and intestine. In both scenarios, patient will have a severe fluid loss and potential for dehydration because of this fistula. In addition to the skin problems, if that's the external intercutaneous, that will lead to the severe skin irritation and skin problems and breakdown. So manifestations in Crohn's disease depend on the anatomic site of the involvement, extent of the disease process, and the presence or absence of complications. So the non-specific complaints like diarrhea, fatigue, abdominal pain, weight loss, and again, that's most patients with Crohn's disease, they have a weight loss because of what we just explained earlier about the pathophysiology consistent with the weight loss and the fever. Now, the principal manifestations, like patients would have, again, we said, in additional to the diarrhea, there is also what is called the fatty stool, which is steatorrhea. Steatorrhea, which spelled out like Steatorrhea, steatorrhea, which is a fatty stool. The abdominal pain, for example, the pain is severe and it's more will be presented or experienced in the right lower quadrant of the abdomen. The abdominal pain also is kind of like abdominal cramping and increased tenderness. Patient may develop a abdominal distension, arthritis, a good number or percentage of chronic patients with chronic Crohn's disease, about like 38% of patients may develop the finger clubbing, which is consistent with finger with this Crohn's disease, more with ulcerative colitis. So there's a finger clubbing that's consistent with the Crohn's disease. Which can be explained or attributed to the mucosal inflammatory change and fibroses mediated by the other pathways. But that's one of the complications that could result from the Crohn's disease, which is the finger clubbing, like patients with COPD and other diseases. So this slide presents some of the complications we mentioned earlier, in addition to others, and diagnostic studies. Medications, sulfasalazine, not effective with ulcerative colitis. So budesonide, which is the intracorticoid, it's a delayed release compound that delivers high local corticosteroids concentrations to the terminal ileum. So they kind of deliver all of these steroids to the terminal ileum and the right side of the colon. So they are extremely effective for Crohn's disease because of this mechanism of action. It's a delayed release compound that delivers the high local corticosteroid concentrations to the terminal ileum and the right side of the colon. So the corticosteroid therapy must be used with caution because of two things. Because of the sepsis and infections. So sepsis may result from the abscess or fistula, and the steroids may mask the signs and symptoms of the infection. the immunosuppressive agents or medications, drugs like Imuran, azathioprine. It's recommended that we give 50 milligrams daily for 12 months, or methotrexate, MTX. There's also antimicrobial like the Flagyl, metronidazole. Flagyl is a brand name. Cipro is a brand name of the ciprofloxacin. And Flagyl or metronidazole is very effective for patients with fistulas. The Remicade, which is an anti-inflammatory drug, it's the monoclonal antibody form of the anti-tumor necrosis factor alpha. Usually it's given intravenous IV, Q8 hours, 5 milligrams per kilogram. And it's treatment of choice for active Crohn's disease and fistula. Humira, fairly new drug. So it's both are MAB, suffix with MAB, like, infliximab, adalimumab, both medications with a suffix of MAB. So the first one, Remicade, we just covered that. And the second one is a Humira, adalimumab. So the Humira is the same classification as the Remicade, as the infliximab. And it's recently approved drug for Crohn's disease. It's contraindicated in patients who are allergic to proteins. So patients allergic to proteins should not take or receive the Humira, adalimumab. Patients should avoid large large crowds and anyone who is sick or ill. And patients should report any signs and symptoms So patients should report any signs, symptoms, or manifestations of infection, including cold and sore throat. So vomiting or emesis, which is a defense mechanism used by body to get rid of or rid itself of, resolve or remove these toxic substances, and it's controlled by the vomiting center, which is located in the middle of the brain, and it's associated with vomiting is one of these conditions or GI symptoms, but it's associated usually with too many conditions, GI and other systems as well. Like the vomiting is associated with infection, with poisoning, with psychological factors, like, can be attributed to the psychological factors. Also can result from, like, pain experiences associated with sometimes vomiting. So pain experience sometimes lead to vomiting, nausea and vomiting. Psychological factors, changes in body position sometimes would lead to nausea and vomiting. Many drugs, medications can cause also nausea and vomiting as a side effect of the drug. So the metrogenic potential, which is the capacity of the drug to induce vomiting. So that's the definition of this term. Capacity of the drug to induce vomiting. Now, excessive vomiting, the danger, or what is the kind of, ramifications or, like, complications from this excessive constant vomiting is that it can lead and result in dehydration and significant weight loss, can lead to a severe acid-base disturbances that can lead to vascular collapse. Now, the treatment of nausea and vomiting, in which that we have to give antiemetics. So we have selective groups of medications or prototype medications to treat the vomiting, like glucocorticoids, dexamethasone, for example, substance P or urocanine 1 antagonist like aprepitant, the serotonin antagonist like ondansetron, like Zofran, very common drug, dopamine antagonist, chlorpromazine, or metoclopramide, Reglan, promethazine, very common medications, very widely used group of meds, either the prochlorperazine or metoclopramide or the promethazine, very widely used like ondansetron. Cannabis like the dronabinol, dronabinol, the cannabis. The anticholinergic drug like the scopolamine, widely used, especially the scopolamine patch, small, tiny, rounded patch being used as an anticholinergic drug, as an antiemetic. The antihistamines like the hydroxyzine or the dimenhydrinate, the benzodiazepine like lorazepam has the antiemetic effect as well. So these are the group of meds that are usually prescribed as an antiemetic medications. In the slide, you will find the drug, the antiemetic drug, the dimenhydrinate, diphenhydramine, like Benadryl, the meclizine or scopolamine. Now, the meclizine, which is antiviral, is a widely used and effective drug to treat patients with tinnitus, patients with nausea caused by ear infections, and with the patient will have when they have an attacks and have the imbalanced gait, and it can lead to like falls due to these dizziness episodes of dizziness and ataxia and dizziness, and associated with vomiting or nausea and vomiting. The antivert is an effective drug for that. The patients with also scopolamine, which is the patch, transdermal patch, 0.5 milligrams q 72 hours. So like we change the scopolamine patch every 3 days will be changed. So these are different indications for these meds. The Avivan, lorazepam, the dronabinol, which is the cannabis, the marinol, the decadron, steroid, the solomidrol, methylprednisolone, the solomidrol, for example. So you have the dosage, the therapeutic use, and the adverse effects of each. Reglan, metoclopramide, the prochlorperazine, compazine, promethazine, Phenergan, and all of these are antiemetic medications for different indications. But the widely used drug for what is called the cancer-induced nausea and vomiting, CINV. The FDA-approved drug for that is the Zofran ondansetron, which is very effective, highly recommended, has been approved for the cancer-induced nausea and vomiting, which is the ondansetron or Zofran. So we'll take examples like a few, examples of these antiemetic drugs like chlorperazine, compazine. So it inhibits the signals to vomiting center in the medulla and the brain. So it will lead to anticholinergic effects like dry mouth, sedation, constipation, orthostatic hypotension, and tachycardia. It may lead to the extrapyramidal symptoms. That's would be a serious concern with prolonged therapy. Now, the emetics, which is to induce vomiting, um, to induce vomiting should only be used in emergency situations. Used only when patient is alert because of risk of aspiration. When a patient is comatose, when a patient is having a gastric lavage, like like an NG tube or a tube is placed and attached suction to emptying gastric contents, that can be done. So some poisons, some toxic material, caustic chemicals should not be vomited because vomiting could induce or result in a further damage to the esophagus as the patient vomits this toxic and poisonous and caustic chemicals. So that should be contraindicated in this condition. Next is the acute pancreatitis, which is an acute inflammatory process of the pancreas. The degree of the inflammation arise, it kind of like, will vary from mild edema to severe necrosis patients. So the inflammation kind of varies from mild edematous tissue, like edema, to severe necrosis, necrotic tissue. Etiology and pathophysiology. The we have a list of all these etiologic factors and causes of the acute pancreatitis, including even medications or drugs like corticosteroids, thiazide, oral contraceptives, sulfonamides, and SADs, and other etiologies like the hyperthyroidism, hyperlipidemia, kidney failure, and we'll explain later about the ERCP, endoscopic retrograde cholangiopancreatography, how this acute pancreatitis can also occur after the ERCP procedure. But in some cases, it can be also idiopathic, in which that we cannot identify, no way you can identify any underlying cause or etiology for this disease process. It can be life-threatening. So what is the pathophysiology of this acute pancreatitis? There is an activation of when there is an acute pancreatitis, then that leads to the activation of the pancreatic enzymes. So first of all, we have etiologic factors. It could be alcoholism or biliary tract disease, like inflammation or disease or stones in the bile duct, or trauma to the pancreas, or infection of the pancreas, or certain medications affected the pancreas, or after the GI surgery, or idiopathic or unknown etiology. So any of these conditions or these factors could lead to the activation to two things: injury of the pancreatic cells and the activation of the pancreatic cells to produce pancreatic enzymes, the amylase and lipase, and trypsin, like for example, and elastase. So trypsin, for example, will lead to, so all of these enzymes, especially the amylase and lipase, these enzymes, they will digest the pancreatic cells and tissues itself. So kind of like, it's called, or lead to the auto-digestive effect or auto-digestion. So kind of the pancreas eats itself. So auto-digestive effects of the pancreatic enzymes that lead result in edema, necrosis, hemorrhage, uh, smooth muscle contraction, and even patient could also develop shock from that, from the severe fluid loss or the decreased fluid, vascular volume, which is dehydration. So severe pain also is a very prominent symptom of this disease process. So again, the etiological factors, um, as we look at the enzymes, for example, so we can just go back to the enzymes. The trypsin, for example, will lead to edema, necrosis, and hemorrhage. Elastase, hemorrhage. Phospholipase A, fat necrosis. Lipase, fat necrosis. So acute versus chronic pancreatitis. So the acute pancreatitis, which is an inflammation of the pancreas resulting from activated pancreatic enzymes, auto-digesting its own cells, auto-digesting the pancreas, and severity varies, but mortality rate is about 10 to 20%. However, the chronic pancreatitis, which is progressive destruction of the pancreas with development of calcifications and necroses, possibly resulting in hemorrhagic pancreatitis. And here, the mortality can be as high as 50%. However, with the acute pancreatitis, the mortality rate was about 10 to 20%. But here with the chronic, it can go up to 50%. Now, the abdominal pain, what is significant about this, or what's the specific, description of, or how patients will experience and describe it? It's, first of all, it's a predominant symptom of the acute or even chronic pancreatitis. Now, the pain is located in the left upper quadrant. It may be also experienced in the mid-epigastrium, but the pain is usually radiates to the back. Sudden onset, severe knife-like, deep, piercing, steady experience of pain, sensation, and usually it's aggravated by lying down or eating, not relieved by vomiting. What would relieve the pain experience to some extent is the patient when they assume the fetal positioning. When the patient assume the fetal position, like raising the knees up and then the hunching the back or curving like in the back and arching the back and head down like in a fetal position, they may relieve the abdominal pain to some extent. So typically, a patient is diagnosed after presenting with a severe abdominal pain in the mid-epigastric area of the left upper quadrant. So that's typical for, and radiating to the back, that's typical for patient, for the pancreatitis. Now, the clinical manifestations and diagnostic studies, you will find that there's a low-grade fever, leukocytosis, like high elevated white blood cells, hypotensive or hypotension, and this is from the fluid redistribution, in which that there is a fluid loss or dehydration, tachycardia, also consistent with fluid loss or fluid redistribution and fluid and dehydration, jaundice, weight loss, flushing, cyanosis, edema, nausea, and vomiting. The complications from this would be like pancreatic infection. Patient may develop abscess or pseudocysts or abscess, hypovolemia, or patient may develop or progress into the chronic pancreatitis. Hypocalcemia is it's prominent. It's one of the significant electrolyte imbalances in pancreatitis, which is hypocalcemia, low plasma calcium level, and elevated glucose level, hyperglycemia. Hyperglycemia and hypocalcemia consistent with pancreatitis. Now we have two different skin changes here or signs. One of them is called a Collins sign, and Collins sign, which is irregular, hemorrhagic. These are kind of patches, like hemorrhagic patches around the umbilicus. These are the Collins sign. And most likely it's going to be like around the umbilicus, like in the middle of the abdomen. And sometimes just not anywhere in the abdomen, but these are the Collins signs. The Turner sign, these are bilateral. This is like a flat. These are the bruising or ecchymotic areas, ecchymoses. They will be present in the flank area, bilateral or one side, or or like most likely is going to be like the left side. So it's a classic finding of the bleeding into the retroperitoneum around the kidneys and pancreas. These are the Turner's signs. Okay, so the seepage of or leakage of the blood stained exudates in the tissues around the abdomen. That's called the sign, and then ecchymotic areas and the flank areas called Turner sign. These are the two different skin changes or manifestations that are consistent with pancreatitis. So we'll cover more content in adult health courses about the treatment and collaborative management in patients with pancreatitis. The medications will include anticholinergic drugs, antibiotics, vitamin supplements, pancreatic enzymes, and we'll just focus here on the pancreatic enzymes as a supplement, as such as the pancreatin or pancrelipase biocase medication. So again, the RCP and MRCP will be covered in adult health courses and as a modality and the complications and the indications for each type, and nursing preparation for each modality. So let's just focus on the medication here, which is the pancrelipase, which is there are different brand names for pancrelipase, but it's a supplement. It's a contains lipase, protease, and amylase of pork origin, and it facilitates the conversion of lipase into glycerol and fatty acids, kind of assisting the metabolism of the lipids. So converts starch into dextrin and sugars, simple sugars, and also converts the proteins into peptides. So it's a replacement therapy for patients with the insufficient pancreatic exocrine secretions, because remember that the pancreas is the only organ that is classified as an endocrine as well as exocrine gland. Endocrine gland because it produces insulin as a hormone and exocrine gland because it produces enzymes. So the drug alert for the pancreatic enzyme replacement therapy, including this pancrelipase, is to take these medications. The pancreatic enzyme replacements should be taken with meals and snacks and glass of water. So instruct the patient who have difficult swallowing either to cover the capsules with applesauce or, if needed, open the capsule and spread the content of the capsule over the applesauce, mash like fruits or rice cereal, and then a patient could take it like mix with it. The enzyme preparation should not be mixed with foods containing protein or any type of protein because the enzymatic action dissolves the food into a watery substance. So again, we should not be mixing this enzyme preparation with food containing proteins. And also, as we educate the patient about the pancreatic enzyme replacement, to be sure that the patient drink a full glass of water after taking the drug to ensure that none of the enzymes remain in the mouth. Because remember this, the enzyme is highly corrosive. It's going to the enzyme will digest the mucosal membrane of the mouth, the buccal mucosa, and that can lead to ulceration and irritation and ulcers and ulcerations. I'll also advise the patient to wipe their lips with a wet towel to prevent the skin irritation and breakdown that could be a residual enzyme has remained, and that can cause the irritation and the skin breakdown. So they are recommended to or advised to wipe their lips with the wet towel right after they take the replacement enzyme to prevent the skin irritations and breakdown. Liver cirrhosis or end-stage renal liver disease. So liver cirrhosis or end-stage liver disease, which is a irreversible inflammatory. So the end stage looks, similar to the end-stage renal disease, ESRD. So that's the last or terminal illness. So it's irreversible inflammation or inflammatory disease that disrupts the liver function and even structure. So the biliary channels, the tiny channels within the liver, they become obstructed from the fibrosis and scar tissue and fibrosis, become obstructed and cause portal hypertension. Because of the hypertension, of this portal hypertension, this is the portal vein. The other slide, probably, let's see, show the portal vein. So if you look at the portal vein right here, going to drain the blood into the liver, in which that liver became like obstructed. So there will be stagnant blood, volume of blood in the portal vein, unable to get through the obstructed channels of the liver because the fibrosis and obstruction, and then can lead to the hypertension. That is called portal hypertension. And that can lead to other problems, like can lead to increase the pressure in the esophageal blood vessels, pressure in the renal artery and blood vessels, drain the blood into the kidneys, blood drained to the lower GI tract, like lead to the hemorrhoids, and to the spleen. So high pressure here, portal hypertension, is going to exert more pressure on the adjacent organs and blood vessels. So, and also, push the blood through the peritoneal cavity into the abdomen, and then the patient will have ascites and fluid retention in the abdomen and the peritoneum. So because of the hypertension, the blood can be shunted away from the liver, and a hypotoxic um, necrosis like hypoxia or hypoxic necrosis will develop. Chronic progressive disease of the liver. There is an extensive parenchymal cell degeneration and destruction of these cells. So the regeneration or regenerative process is disorganized. The liver is unable to regenerate itself because we know that the liver has a high tendency and ability to regenerate its cells to a full capacity or to full, full organ capacity. But here, this regenerative process is disorganized and lead to result in a abnormal blood vessel and bile duct relationship from fibrosis. Now, the etiology in terms of the types of the liver cirrhosis, and which that the liver cirrhosis is the same as end-stage liver disease. So liver cirrhosis or end-stage liver disease, it kind of interchangeably kind of use terms. So the liver cirrhosis, it could result from the alcohol or due to the post-necrotic like conditions or changes in the liver. Due to the necrosis or due to the biliary problems like stones and the biliary duct or common bile duct, or cardiac related. Or so we can attribute the liver cirrhosis and classify it to 4 different groups: alcoholic Lennox cirrhosis, post-necrotic cirrhosis, biliary cirrhosis, and cardiac cirrhosis. So as we differentiate between these 4 different types, like for example, alcoholic cirrhosis, which is associated with alcohol abuse and usually preceded by irreversible fatty infiltration. So before the patient developed this the liver cirrhosis, they develop the fatty liver before they get into the liver fibrosis and then cirrhosis. So again, with the alcoholic cirrhosis, it's preceded by irreversible fatty infiltration of the liver cells. So that's a good sign, is that it's reversible if the client stops drinking. So it's a widespread scar tissue formation here. With the second type, which is post-necrotic cirrhosis, a complication of toxic or viral hepatitis. That could be attributed to toxic chemicals, drugs, medications, or idiopathic like autoimmune disease. The post-necrotic cirrhosis accounts for about 20% of cases of cirrhosis. And there will be like broad bands of scar tissue will be formed within the liver. The biliary cirrhosis, the third type, which is associated with chronic biliary obstruction and infections, and either in the cystic bile duct or the common bile duct, and accounts for about 15% of cases of cirrhosis. Here, with the biliary cirrhosis, there is a diffuse fibrosis of the liver with jaundice as the main feature of this type. The biliary causes of cirrhosis include like biliary obstruction, stones in the common bile duct, or stones in the cystic duct, that will lead sometimes results from other conditions like ulcerative colitis. Once patient develop what is called the primary sclerosing cholangitis from as a complication of ulcerative colitis, patient may end up with a with the biliary cirrhosis. The last one type of which is the cardiac cirrhosis, which usually results from the long-standing severe right heart failure in patients with a cor pulmonale or constrictive pericarditis or tricuspid insufficiency. So the clinical manifestations of the liver cirrhosis, the onset of this disease or liver cirrhosis or end-stage liver disease is insidious. So in which that, the disease, when we say insidious, it's like, operating or proceeding in an inconspicuous or seemingly harmless way, but actually with grave effects. So it seems like it's harmless, but it's actually, the actual effects are really very harmful and very serious. So this, the nature of this disease explains that, or actually it's indicated in which that 40%, almost like half of the cases of patients with liver cirrhosis, they are asymptomatic. And that's the major issue with that, is that patients with about 40% of cirrhotic patients, they are asymptomatic, no symptoms. They are not presented or exhibited with any symptoms. So they will be presented. So the presentations or manifestations will include GI disturbances like, anorexia, dyspepsia, and flatulence, and nausea and vomiting, and change in bowel habits. The late manifestations, so there are two main mechanisms that will lead to these manifestations. The failure of the cells of the liver cells, which is hepatocellular failure, and the portal hypertension that will, which the complications in which we explained earlier as part of the pathophysiology of the end-stage liver disease or liver cirrhosis. In addition to the patients will have the low-grade fever, abdominal pain, lassitude, which is the lack of energy, the weight loss, and the enlarged, which is hepatomegaly and splenomegaly. Now, the manifestations of the liver cirrhosis, they kind of encompass and cover affects almost all body systems. And jaundice, for example, occurs so patients develop jaundice because of the insufficient conjugation of the bilirubin by the liver cells and the local obstruction of the biliary ducts by scarring tissue, by the scar tissue and fibroses, and the scar tissue. So patient will have intermittent jaundice, like periods of very prominent and very, severe jaundice, and other remission phases of very mild or no jaundice. So they develop this kind of intermittent jaundice. But the late stages of cirrhosis, the patient will usually have sustained jaundice. Yellowish discoloration of the skin and the sclera of the eye. Skin. Patient develops spider nevi, spider angioma, or telangiectasias. All means the same thing about the spider changes, like spots in the or tiny small blood vessels It's like small dilated blood vessels with bright red center point, and the spider-like branches, and that it will be, these kind of, spider nevi or angiomas will be present and seen in, like, in the nose and cheeks and the upper trunk, the neck, the shoulders. These are very prominent and evident of the liver cirrhosis. The palmar erythema, which is a severe redness, like a red area that blanches with pressure located on the palms of the hands. Now, both of the above lesions of either spider angioma or erythema, which is the redness of the palm, um, both of these lesions are attributed to the increased circulation of the estrogen due to the inability of the damaged liver to metabolize the estrogen. So the spider angioma, spider nevi, the telangiectasis, all these things are or changes are can be attributed to the inability of the liver to metabolize the estrogen. Endocrine disturbances, steroid hormones of the adrenal cortex, aldosterone, testes and ovaries are metabolized and inactivated by the normal, healthy liver. So the alteration in the hair distribution also can be attributed to that. There's a decreased amount of pubic hair. There's an axillary and a pectoral alopecia, hematologic disorders like bleeding tendencies. And this is a huge problem and issue in patients with liver cirrhosis. They tend to bleed and have a tendency to, for the bleeding hemorrhage constantly. And we have to be careful with the, with the needle stick, with the insertion of any, like, any invasive procedure and any surgical, like, intervention. We have to be careful with, with that kind of, anticipated bleeding tendency. So, and that's because of the decreased production of the hepatic clotting factors. Patients, diseased liver unable to produce clotting factors like factor 2, 7, 9, and 10. All of these are significant factors that may contribute, and deficiency of these clotting factors may, contribute to the bleeding tendencies. Patient develop anemia, leukopenia, low white blood cells, and thrombocytopenia, low um, 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 platelets. They all believed to be the result of the hypersplenism because of the splenomegaly, and the splenomegaly resulted from the backup of blood from the portal vein into the spleen. And overactivity of the enlarged spleen results in increased removal of blood cells from the circulation. So there is an inadequate red blood cell production and survival. There is patients also tend to have, like, bleeding from the esophageal varices. We'll cover that under the GI tract. And so the anemia can be attributed to more than one just factor. It's, the splenomegaly, inadequate red blood cell production and survival, poor diet with poor absorption of folic acid, and the bleeding tendency, and especially from the esophageal varices. Patient develop also peripheral neuropathy, which is a common finding in alcoholic cirrhosis. That's due to the dietary deficiencies of the vitamin B1, thiamine, folic acid, and vitamin B12, cyanocobalamin. And that would result in a mixed nervous system symptoms, but the sensory symptoms will predominate. Now, complications. Patient may develop a portal hypertension and esophageal varices. In which the portal hypertension, which is abnormally high blood pressure and the portal vein, caused by resistance to the portal blood flow into the liver, because the liver is cirrhotic and fibrotic and obstructed. And it will be characterized by increased venous pressure and the portal circulation, splenomegaly, esophageal varices, systemic hypertension, renal hypertension also, and increased pressure like on the renal vein or arteries. And also there is an increased risk for hemorrhoids due to this portal hypertension. Patients develop a severe complication from this, or the most con concerning complication from the portal hypertension is the esophageal varices. So esophageal varices looks like here, which is the thin, um, delicate blood vessels in this in esophagus. So it's the increased blood flow through the portal system would result in a dilatation and enlargement of the plexus veins of the esophagus and produces like varices. And these varices are fragile, delicate vessel walls, which will easily bleed with any with mild or like minimal pressure, like intra-abdominal pressure, coughing, sneezing, increased intrathoracic, intra-abdominal pressure sometimes will lead to the rupture of these varices and result in severe hematoemesis and bleeding. So the And another complication is the hemorrhoids from the portal hypertension. We said internal hemorrhoids, which will occur because of dilatation of the mesenteric veins and rectal veins. Peripheral edema and ascites. So patient develop ascites, looks like this, in which there is intraperitoneal accumulation of water fluid containing small amounts of protein. So as the protein filtered from the portal vein into the peritoneum, it pulls more fluid and water into the abdomen and makes it, the scenario even gets worse of more fluid accumulation in the abdomen, more ascites, and that's due to the leakage of the protein in the peritoneum and the abdomen. So the factors involved in the pathogenesis of the ascites: hypoalbuminemia, so protein being pulled with this hydrostatic pressure and the portal vein, pushing fluid and protein into the peritoneum, and there is an increased level of aldosterone and increased portal hypertension. The three mechanisms makes this vicious circle of patient or cycle of ascites, and patient will, and if you can tell from these scar spots of scar tissue, these spots of scar tissue are, and in the case the patient has went through several paracenteses, which is the aspiration of the fluid from the abdomen as a technique and modality to treat the ascites and remove the fluid from the abdomen. The hepatic encephalopathy, which is the accumulation of the ammonia and the plasma as a result of the inability of the cirrhotic liver, failed liver, to convert the ammonium, convert the ammonia to ammonium, and the ammonium is less toxic material than ammonia. So the ammonia will stay in its toxic form, and the most sensitive cells, or the cells that are more sensitive to the ammonia, is the brain cells. So this explains that it's a neurologic syndrome of impaired cognitive function, flapping tremor, and EEG changes. So the condition develops rapidly during fulminant hepatitis or slowly during chronic liver disease. So it is the encephalopathy is the there is a wide range, this like continuum of the encephalopathy goes from like the minimal of confusion and change of mental status down to the most serious on the continuum, where like, patient may lose consciousness, and that's hepatic coma. So it's all due to the accumulation of the ammonia in the blood. So high plasma level of ammonia results in the neurological problems. So the patient become like combative, behavioral issues, or like, being resistant to care and confused and being combative. That all of these are behavioral changes in response to the acute accumulation of ammonia in the blood. So the liver damage causes blood to enter systemic circulation without liver detoxification. In other words, that this ammonia will never be detoxified into ammonium, which is less toxic, and it will stay in its ammonia, like form, which is the pathogenic toxin. And again, the cells that are most sensitive to this is the brain cells. So the asterisk is, which is a liver flapping tremor, and it takes many forms. Patient is unable to hold the arms and hands stretched out, unable unable to hold this position with a series of rapid flexion and extension movements of the hand. So it's a sign of a advanced stage of liver cirrhosis, and advanced stage of the encephalopathy, hepatic encephalopathy, due to the accumulation of the ammonia in the blood. So hepatic porphyrias hepaticus, another like symptom consistent um, with liver cirrhosis, in which the patient would have like a musty, sweetish odor detected in the patient's breath, musty, kind of sweety odor. And that's from the accumulation of digested byproducts that the liver is unable to degrade or detoxify. And patient may develop also a spontaneous bacterial peritonitis, SBP, due to the decreased level of protein as it protects against bacteria. Diagnostic tests will cover more of the tests in adult health courses, in addition to the nursing care. But the most prominent thing is that you'll find there is an elevated ammonia level due to the liver cirrhosis. So hepatic encephalopathy, to treat it, I mean, obviously we have to reduce the ammonia level, make it less toxic, and restrict the protein, and sterilize the GI tract, and so we can also trap the ammonia in the GI tract and can be reduced or resolved, excreted with the bowel movement. And medications to treat that would include lactulose and rifaximin. These are two very effective medications to treat the high ammonia due to the liver cirrhosis. Um, in addition, also to medications like diuretics, for example, so we have to monitor the patients for hypokalemia and hypotension, H2 receptor antagonist, that's to prevent the stress ulcers, and lactulose to decrease the ammonia level and trap the ammonia level in the GI tract and bowel movement to be released with bowel movement, so we can treat the high ammonia plasma ammonia level. Neomycin, flagyl, vancomycin, these are the antibodies that are going to work as or function as the GI sterilizers or like sterilization of the GI tract, and we can, remove these bacteria, the flora that could be the source of this ammonia as well, because the ammonia level, ammonia sources are either protein metabolism or the flora, good bacteria in the GI tract. So if we can eliminate with the low protein diet and eliminate this flora or bacteria, we can lower the ammonia level to high extent. And the last condition, GI condition here, which is cholecystitis, which is either acute or chronic. It's an inflammation which is caused by the obstruction, blockage in the biliary system, mostly from stones. That's the most prominent, more, let's say, prevalent even, cause of this cholecystitis, which is the inflammation due to the obstruction or blockage in the biliary system from stones, which is cholelithiasis and cholecystitis. So approximately 8 to 10% of American adults have this cholelithiasis, which is stones in the gallbladder, and the cholelithiasis, which is the stones in the gallbladder, develops when the balance that keeps cholesterol, bile salts, and calcium in solution is altered, so that the precipitation of these substances will take place, and then the cholesterol, the most common type of this cholelithiasis or these stones in the gallbladder are of a cholesterol type. Most common type is cholesterol stones. Other stones that are found in patients with liver cirrhosis, they are like pigmented stones or pigment stones, but the most common one is the cholesterol stones. The impaired gallbladder motility that could lead also, or peristalsis can also lead to the, store formation. So there are two different types of cholecystitis. The one which is with stones, which is calculus, and there is also E-calculus cholecystitis. But the most common type of the calculus cholecystitis, which is cholecystitis due to the stones, calculus cholecystitis, in which the chemical irritation and inflammation result from the gallstones, like cholelithiasis, stones in the gallbladder, in which that will obstruct the cystic duct or the common bile duct. However, there is also another type of cholecystitis, which is called E-calculus cholecystitis. The E-calculus cholecystitis, which is purely patient will develop the cholecystitis, which is inflammation occurring without gallstones. It is typically associated with biliary stasis caused by any condition that affects the regular filling or emptying of the gallbladder. So, for example, a decrease in the blood flow to the gallbladder, or the anatomic problems like the twisting or the kinking of the gallbladder neck, or the cystic duct. This kinking and twisting of this duct can result in a pancreatic enzyme reflux into the gallbladder, can result in obstruction. or obstructing the gallbladder neck or cystic duct, leads to that the pancreatic enzyme will reflux into the gallbladder and causing the inflammation. And most of cases of this type of cholecystitis, which is the acalculous cholecystitis, which is again the cholecystitis that would result and occur without gallstones and due to the kinking or switching, kinking or twisting of the gallbladder neck or the cystic duct. Patients who may develop this, like patients with sepsis, with severe trauma or burns, patients with long-term TPN, total parenteral nutrition, patients with multi-system organ failure, hypovolemia. These are kind of common causes or etiologies for this acalculous cholecystitis. So risk factors, the cause of the gallstone is unknown. So this is the cholecystitis, the cholecystitis with stones. The incidence of cholelithiasis is higher in women, multiparous women, and persons over 40 years of age. So the postmenopausal women on estrogen therapy are at somewhat great risk of having gallbladder disease than our women who are taking birth control pills. The oral contraceptive, they change or alter the character of the bile, resulting in increased cholesterol saturation. So there is kind of high link or association between the oral contraceptives and the highest saturation of the cholesterol saturation in the biliary tract or the bile duct, which could lead to the more stones and more inflammation and cholecystitis. So other factors um, listed here as the familial, like sedentary lifestyle, familial tendency, obesity. So like the nutritional habits, like excessive dietary cholesterol intake, like high cholesterol diet can be one of the factors or main factors. Now, the manifestations of cholecystitis vary from indigestion to moderate to severe pain, fever, jaundice. So there is under the manifestations, we have like a biliary colic, which is we'll get back to the Murphy's sign as one of the significant signs of cholecystitis, but the biliary colic, which is the severe pain of biliary um, uh, tissue or duct or tree in which it is produced, this specific type of pain is produced by the obstruction of the cystic duct of the gallbladder or movement of one or more of the stones. So when the stone is moving through or is lodged within the duct, then the tissue spasm occurs in an effort to get the stone through the small duct. So this is called biliary colic, and it's extensive and severe pain. Um, However, the Murphy's sign, in which is consistent or it's one of the as we diagnose or differentially diagnose patients with cholecystitis, and we are looking for to assess for the Murphy's sign, which is pain with deep inspiration during the right subcostal palpation. As we palpate in the subcostal region, then patient will experience severe pain with a deep inspiration as we palpate the right subcostal area. That's called Murphy's sign. Patient experience that severe pain sensation with when they take deep breath with deep inspiration. Um, the biliary colic may be so severe that it occurs with the associated with the tachycardia, pallor, and diaphoresis, and prostration, which is the extreme exhaustion. So patients should be assessed for possible shock caused by the biliary colic. So one of the interventions that we have to stay with the patient. So we have to notify the healthcare provider for a rapid response team if these manifestations occur, and also we have to stay with the patient and lower the head of the bed. Now, patient also develop what's called the steatorrhea, which is the fatty stools, and also another sign is called Bloomberg sign. And the assessment of no for the this Bloomberg sign, which is rebound tenderness, it's kind of assessing for the rebound tenderness, and deep palpation are performed. So this type of I'm not going to go over this because this is a procedure or assessment technique that should be performed only by the experienced practitioners or physicians, nurse practitioners or physicians, advanced like practice nurses or MDs, who should be qualified to do this specific procedure. So, but briefly, to elicit the rebound tenderness, the healthcare provider will push the his or her fingers deeply and steadily into the patient's abdomen, and then quickly release the pressure. Now, pain that results from the rebound of the palpated tissue, it may indicate peritoneal inflammation. Now, the deep palpation below the liver, border in the right upper quadrant, may reveal a sausage-shaped mass representing the distended, inflamed gallbladder. Percussion over the posterior rib cage that worsen localized abdominal pain. So these procedures, ERCP, MRCP, all these procedures will be and modalities will be discussed again in the adult health courses, in addition to the lap chole, cholecystectomy, or laparoscopic cholecystectomy. Same thing is going to be discussed in adult health courses as well. And that concludes, or this slide concludes the lecture.